I'm going to be discussing the 3-minute foot exam for diabetes. And this is going to take in, I think, a lot of what some of the other speakers have been talking about, and putting it into something quick and easy to use in the clinical setting. So let me share this. All right, can you see this on full screen?
Yeah, it's perfect.
Okay, perfect. All right, so how to perform a 3-minute foot exam. And so there's a lot of things that you can do in 3 minutes. You can style your hair. You can learn English, although this is not American English. This is a British English, but you can learn some form of English. You can do a 3-minute workout while you're watching TV, where you can soft boil an egg. But what you can also do is examine a diabetic foot and create a risk assessment, and also work in some education into the patient. Now, I'll tell you that you'll probably never do an exam in 3 minutes. This is really a guide, but it should take you somewhere between 5 and 7 minutes to do this and provide appropriate education afterwards. So don't book 27 of these an hour. You've got to practice your time and use it a little bit more efficiently. So we're going to cover what you should be doing in the first part, the second part, and the third part. These are all broken down in this article into different minutes. But minute 1, you're going to take the history. Minute 2, you will do an exam. And then minute 3, focus on teaching. First, about amputations. The World Health Organization and the International Diabetes Federation both have estimated that up to 80% of amputations are preventable. And even the St. Vincent's Declaration called for a reduction in amputations by 50% over the next decade. And you can see this was written in 1999 or 1990. And over the next decade to 2000, they did not realize that 50% reduction, and in fact had an increase worldwide in the rate of amputations. So it's important for us to know the natural history of diabetes-related amputations. It's not just a single step that because you have diabetes, you'll end an amputation. In fact, there are several steps that occur in between those two endpoints. First, you have the diagnosis of diabetes. After 8 to 12 years, peripheral sensory neuropathy usually ensues. Then after repetitive trauma, there can be an ulceration. Some patients have vascular disease, some don't. It's somewhere around 50% of those with an ulcer will have significant vascular disease. But it's almost always the infection that is the coup de grace, the final blow that leads to the amputation. And so when we look at how to classify someone's risk, we think about this natural history and where they are on this stairway to an amputation, and how do we de-escalate their risk and in essence prevent the amputation. So let's ask, who is at risk for a lower extremity amputation? The risk factors for amputation were described in a classic article by Roger Pecoraro in Diabetes Care in 1990. But of the limbs that were amputated in this study, 84% of them had an ulcer on them at the time they were amputated. 59% were infected at the time they were amputated, and 55% exhibited gangrene when they were amputated. There are big disparities in amputation rates. People who are older, males, ethnic minorities have a higher rate of amputations. In the United States, those in the South have a higher rate of amputation. And also, if a patient is uninsured or underinsured, they have a higher risk of amputation. And this is a problem that we see around the world, but mostly due to a lack of access for quality care. So I asked who is at risk for an amputation. Well, now let's say who is at risk for a diabetic foot ulcer, since it's the foot ulcer that often starts the spiral for the amputation. The risk factors for a foot ulcer include diabetic peripheral neuropathy, peripheral artery disease, foot deformities, but the biggest risk for a future foot ulcer is a history of a past foot ulcer or a partial foot amputation. And it's been said that up to 25% of those with diabetes will develop a foot ulcer in their lifetime. So now let's focus on these 3 minutes. And, I'm sorry it's going to take me 30 minutes to teach you how to do an exam in 3 minutes, but this is what we're going to do. So the minute number 1, we're going to ask about the patient's history. For a diabetic foot exam, you don't have to ask about every aspect of their history or even every aspect of their foot history. You should limit, especially if you're limited by time, limit your questions to those that convey future risk. And that will save you more time and you can be more efficient. So you first see if the patient has a history of previous leg or foot ulcer or lower limb amputation, yes or no. Prior angioplasty, stent, or leg bypass, yes or no. Foot wound, smoking or nicotine use, and is there diabetes? Is it controlled? Also, we're going to ask if they have burning or tingling in the legs or feet, symptoms of diabetic peripheral neuropathy. Leg or foot pain with activity or at rest, sometimes a symptom of peripheral artery disease. Changes in skin color or skin lesions, and then loss of sensation in the lower extremities. All right, so we're already on minute number 2. This is the longest one of the presentation, but this is the exam. And this is what do you look for? So it's important to note that there are 4 major systems that we divide the lower extremity exam for diabetes into: the dermatologic exam, neurologic exam, musculoskeletal exam, and vascular exam. And we'll cover all of those briefly here. So what do you look for in the dermatology exam? Does the patient have discolored, ingrown, or elongated nails? Oh, sorry, let me go back here. You can see this. Can you see my pointer or no? Is this, it's sometimes you can see it on Zoom and sometimes you can't.
Yeah, we can see the pointer. Okay.
So here you can see that the medial nail fold had an ingrown nail. This was removed, and so this is absent now. But there's inflammation around the medial nail fold. In this picture over here, we're looking at elongated and, in this case, fungal toenails. You can also see the poor skin condition here, probably just overall poor hygiene. So the first thing we do is we look at their nails as part of the dermatology exam. Then we look and see if there's any sign of fungal infection. Now, fungal infections are more common in those with diabetes because of immune suppression from diabetes. So here in the right picture, we can see some thickening of the toenail with cracking and some subungual debris here and here in the third toenail. This is consistent with onychomycosis. But also, this is a tinea infection or athlete's foot in this patient, and this one is rather erythematous or red. Many times in people with diabetes, they can have fungal infections in between their digits and not exhibit any signs of inflammation due to the immune suppression. So you have to have a high index of suspicion for that. Also, pull the toes apart and look for interdigital maceration, which can be a sign of fungal infection as well, or just excess sweating or poor hygiene, but also leads to other problems, including ulcerations and other infections. Now we're looking still in the dermatologic exam. Are there any hypertrophic lesions, calluses, or corns? You can see in this photo, there is a hyperkeratotic lesion or a corn on the lateral surface of the fifth toe. And this is almost always due to pressure from a shoe. Anytime you see a hyperkeratosis on the top of a toe or on the side of a toe, it's almost always due to improper fitting footwear. And then this one over here looks even more ominous. You can see that it's dark underneath it. I'm sure if you debride this, you probably would find an ulcer underneath this callus, but David Armstrong has often equated a callus on a diabetic foot to a lump in a breast. Since there are lots of similarities between the mortality rate of various cancers, and in fact, the mortality rate after amputation is even higher than many cancers. But if you're doing a self breast exam and you find a lump that's suspicious and it involves a further workup, when you're doing a foot exam and you find a callus, especially a discolored callus, that should be an indicator of a major problem, and we should seek help in that case. So then we also look if there are any open wounds or fissures. This is a picture of a patient's heels while they're laying prone on an examination table, and you can see that the heels are cracked here. And then this is a frank ulceration, probably grade 2, or if it probes to bone, it could even be grade 3 ulceration. Now we're on to the neurologic examination. Neurologic examination is relatively simple in somebody with diabetes. If they have a foot ulcer already, you don't really need to do a neurologic examination because they already have loss of protective sensation. And that's a more severe form of peripheral neuropathy. And you can already check that box that they have peripheral neuropathy. But if there is no ulceration and you're doing an overall risk assessment to determine if they will develop a foot ulcer, then there are a couple of tests that you can use. There's more than a couple actually, but I'll give you the two easiest. The two easiest are one, using the Sem-Weinstein monofilament, or two is using the Ipswich touch test. And the monofilament is used like this, where it is this provides 10 grams of pressure in this filament. These are all nylon filaments now. They used to be horse hairs from a horse's tail at various diameters, and they would buckle under certain pressure, but now they're all calibrated and nylon. And now this will buckle at or bend at 10 grams of pressure. And that should be sufficient for somebody to feel. And if you did this on your own hand, you could feel it. And so you're doing it on a patient's foot. You have the patient close their eyes, and then you test these areas on both feet, and you ask them. It's called a forced choice, yes or no, where you push it on them, and then you say, "Do you feel it now? Yes or no?" And then you do a couple of them where you're not pushing, just to make sure that the patient is feeling what you're doing. And if they miss, you really only have to do 4 points. You could do 1, 2, 3, 4. That's been shown in several studies to be sufficient. Some other studies recommend 10 points, so 9 on the plantar surface on the foot, and then 1 in between the big toe and the second toe on the dorsum. But I only do 4 points: the hallux, and then the first metatarsal head, the third metatarsal head, and the fifth metatarsal head. If they miss any one of those points, that's loss of protective sensation. Then the Ipswich touch test is if you don't happen to have a monofilament with you, you would push your finger down on a digit enough to cause pressure, obviously, for you to feel it. But you test all the digits, and if they miss 2 of them, then that is considered loss of protective sensation. So I'm sorry, it's six digits total. The first digit, the third digit, and the 5th digit on both feet. So that's 6 total. If they miss 2 or greater, that is considered loss of protective sensation. So that's pretty simple to do if the patient does not have an ulcer. If they have an ulcer, you move on to the next, which would be the musculoskeletal exam. Musculoskeletal exam can give you sometimes clues to why the patient has an ulcer in a particular location. Really, there are 2 joints that need to be examined, only 2 that convey the largest risk in the diabetic foot. Number 1 is the ankle joint. And so you'll have the patient prone on the table, and you will try to dorsiflex the ankle, and you're looking at the angle here, so where the foot is in relation to the leg. And normally there is about 10 degrees of dorsiflexion or more for healthy ambulation. With diabetes, because of various processes that occur in the Achilles tendon and in the muscles, you can have limited dorsiflexion, and then that increases the pressure underneath the plantar forefoot, which increases the risk of ulceration. So that's why we check the ankle dorsiflexion. We also check the dorsiflexion of the big toe joint. So you take the hallux or the big toe, the first toe, and you dorsiflex it. Normally, you would expect 45 to 60 degrees of dorsiflexion. If it is limited, that's called hallux limitus. If it's less than 45 degrees, it would be hallux limitus, and that can indicate that there is arthritis in the first metatarsophalangeal joint. Also, it could have no motion whatsoever because of really advanced arthritis, and that would be hallux rigidus. But in any case, if there is less than 45 degrees of dorsiflexion of that joint, it increases the risk of a foot ulcer underneath the big toe itself because of the increase in the pressure from abnormal ambulation and abnormal pressure. So then we look for any obvious deformities that the patient might have on their feet. Here, this patient has a bunion deformity, you can see, and also has a hammer toe. So this, you can see there's pressure here and there's pressure here. Those are signs of, this is not a person with diabetes, but if they did have diabetes, that would be a sign of risk for future ulceration here. Now, this is another example of a more severe deformity, bunion deformity, where the first toe is crossing over underneath the second toe. This causes a lot of abnormal mechanics, and not only there's less space in the shoe to accommodate the depth here, so there's extra pressure that's occurring on the dorsum of this digit. There's extra pressure that's occurring over here, but there's also rubbing that occurs in between these 2 digits and can result in an ulcer or a break in the skin. Then also in the musculoskeletal exam, we're going to look for signs of Charcot foot, and I'm going to talk about Charcot foot in an entire lecture later on this afternoon, so I won't do it now, except to say we look at see if the foot is hot, swollen, or red, and those are signs of Charcot foot until proven otherwise, and we'll get into that later in another lecture. So now we're on to the last part, which is the vascular exam, and this is kind of difficult because this is only using your clinical judgment and your clinical exam. And the clinical exam is not always reliable in somebody with diabetes, but it's sometimes the only thing we have to do. So the correct way to do a clinical exam, even as unreliable as it is for vascular disease, is to palpate both the dorsalis pedis and the posterior tibial arteries. The dorsalis pedis is on the top of the foot, and the dorsalis and the posterior tibial is behind the medial malleolus on both ankles. And you would palpate that, and you could even characterize it according to a graded scale of 0 if it was absent, 1, 2, 3, and 4, and actually 2 is normal, 4 is excessive or bounding in that case, and that's really based on your subjective judgment on that scale. A more proper way to determine if a patient has vascular disease would be to use a non-invasive vascular screening tool. You could use an ABI, although the ABI, which is called the ankle brachial index, that also is affected by diabetes and may be falsely elevated or falsely normal. There are some other tools out there that give you more sensitive assessment of vascular disease in somebody with diabetes, but we just focused on the clinical exam for now. So now we're at the end of our exam, and this is where you do your risk assessment before you go into the teaching, because now you need to know where the patient is before we determine what to teach them. And I'll make this larger so we can all see it. The risk categories are over here. Let's look at these bottom 4 right here. So risk category 0. This is a patient that does not have loss of protective sensation or peripheral arterial disease. They just need to see a specialist within 1 to 3 months and then have an annual exam. A patient that is at risk category 1 has loss of protective sensation. So this is neuropathy, and they need to be referred within 1 month to a specialist and then should be seen every 4 to 6 months. Patients that are risk category 2 have peripheral artery disease with or without loss of protective sensation. So these pulses that I just described, the dorsalis pedis and the posterior tibial, they're either diminished or absent. And there can also be swelling or edema present. Now, this is a more urgent referral, requires a referral within 1 to 3 weeks to see a specialist, and then they should be followed up every couple of months. And now the highest risk category is a risk category 3, and this is a patient, as I said, that had a history of an ulceration or a history of an amputation or has Charcot foot. And those patients need an immediate or next available appointment in the outpatient center and then be followed up every 1 to 2 months because they're at higher risk for a future ulcer. And then you can see this category up here. This is not part of the risk category. This just shows up on this table. The risk category is only 0 through 3, but this is a patient that that is not appropriate for the risk category because they have active pathology. So once they have an open wound or a new Charcot foot or gangrene, that's an immediate referral and then followed up as necessary. So now we're in the last minute of your 3-minute foot exam, and this is your teaching session, what to teach. And I'll argue that this is probably why the 3-minute foot exam takes longer than 3 minutes, because it's important for us to really convey to the patients what they need to understand. I recommend actually creating a video of yourself talking about your recommendations for their foot care. So not only can you say it during a clinic visit, but you can email it to them or text it to them, and they can watch it as often as they want. And we find that patients who have this constant, this resource available for viewing, they can refresh their memory better. So recommendations for daily foot care: patients or a family member should visually examine both feet every day, keep their feet dry. If they're using a moisturizer cream, don't put it in between the toes. Cut their toenails straight across, not into the corners. Don't do any bathroom surgery. That's a term we use if they try to perform some little procedure on their foot or a callus or something like that at home. And then report any new lesions to a foot care professional immediately. Recommendations for shoes. We tell patients don't walk barefoot even in the house. The shoes protect their feet even when they're walking around in the home from stepping on things and injuring their feet, kicking furniture, etc. Wear appropriate sized footwear. There have been several studies that have shown that people with diabetes, because of neuropathy, choose inappropriately sized footwear. They need that extra sensation from a tighter shoe to think that it's fitting. And so they may choose shoes that are half or one size too small. And so they should get measured if necessary to make sure they're wearing the appropriate sized footwear. If there are any lesions on the foot, custom shoe modifications might be necessary to take the pressure off those lesions. And then they should get shoes at least yearly. The overall health treatment recommendations: smoking cessation if applicable, recommend tight glycemic control, limit weight-bearing exercise if neuropathy is present. You don't want to recommend a patient with peripheral neuropathy to do a lot of weight-bearing exercise like walking or any type of high-impact exercise that's going to increase the risk of ulceration. I do want to take just a minute and mention Dr. Paul Brand, who is dead now, but he was a pioneer and discovered the link between neuropathy and foot ulceration. He discovered it in India in people with leprosy, wrote a book called Pain, the Gift Nobody Wants, and he gave the keynote address at the Diabetic Foot Update in San Antonio, Texas in 2002, right before he died. And I've posted this on my YouTube page, and you can go and watch his keynote address on how to use the cardinal signs of inflammation, especially heat or calor, to determine risk for ulcer, since patients without pain, they've lost dolor, pain, the gift of pain, as Dr. Brand says, and must rely on some other mechanism. But I encourage you to look at that video. I will stop now and happy to take any questions.